Ladies and gentlemen, before we continue further into our seminar for today, we will now be led in prayer. Berikutnya adalah pembacaan doa. Dalam hal ini akan dipimpin oleh Bapak Azwar Zulkifli Syam, Sarjana Kesehatan Masyarakat, Magister Kesehatan Masyarakat. Kami persilahkan.
Okay. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning, everybody. The Honorable all the participant international seminar of Keluarga Alumni Gadjah Mada Central Sulawesi Branch. Please allow me to read a prayer in Islamic guidance. Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alamin. Wassalatu wassalamu ala Rasulillah. Nabiyina Muhammadin sallallahu alaihi wasallam. Allahumma ya Allah, ya Rahman, ya Rahim. Allahumma ighfir lil muslimina wal muslimat wal mu'minina wal mu'minat al ahya'i minhum wal amwat. Allahumma Rabbi zidna hilman warzuqna fahman. Allahumma harinal haqqan haqqa warzuqna ittiba'ah wa arinal batilan batila warzuqna ijtinaba. Allahumma ya Allah, ya Rahman, ya Rahim, ya mujibas sa'ilin. Allahumma inna as'aluka hilman nafi'a wa rizqan tayyiba wa hamalan mutaqabbala. Allahumma amin, ya mujibas sa'ilin. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzaban nar. Wa sallallahu ala nabiyyina Muhammad wa ala alihi wa sahbihi wa sallam. Walhamdulillahi rabbil alamin. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you. Next, ladies and gentlemen, before we continue, I would like to apologize for the technical difficulty that we just experienced. Next, ladies and gentlemen, we will now hear a report from the committee's chairman. Selanjutnya adalah laporan ketua panitia yang akan disampaikan oleh Dr. Putu Malaya, Master of Public Health. Waktu dan tempat, dokter, kami persilahkan.
Thank you very much for my turn. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera buat kita semua. Om Swastiastu, Namo Buddhaya. Praise gratitude for the presence of Almighty God, because therefore we can gather today with a full of blessed. Good morning, ladies and gentlemen. Welcome to the virtual international seminar today. Let me introduce myself. My name Dr. Putu Melaya MPX as Chairman of the International Seminar Organizing Committee. This international seminar event is a collaboration between the Gadjah Mada Universitas alumni family and the Faculty of Medicine Tadulako University. The initial plan for this international seminar was to be face-to-face offline in July 2020, but due to the COVID-19 pandemic, there were no speakers to come to Indonesia. We apologize for the delay in carrying out this seminar to all participants who have registered. This international seminar was attended by 4 countries as speakers: the United States, Thailand, Malaysia, and Indonesia as the host. Faculty of Medicine Tadulako University funding for this international seminar. All proceeds from participant registration will help people affected by health problems due to COVID-19 in Palu City. I report that this international seminar aims to find out other countries' experiences in implementing health insurance and coverage for chronic disease and emerging disease, including COVID-19. The number of participants in this international seminar was around 513 participants was registered, consisting of doctors, midwives, lecturers, public health, pharmacists, but from Indonesia and several other countries. They also work as students at several medical faculties in Indonesia. Thanks to all speakers, the Dean of the Faculty of Medicine University of Tadulako and Prof. Amar, who is currently the Deputy Chancellor for Development and Cooperation of University Tadulako, will give remarks as officially open this international seminar. Thank you very much.
Thank you, Dr. Putu Malaya, for the report. Ladies and gentlemen, now we will enter the next event. We will be hearing delivered speeches first from the Dean from the Faculty of Medicine Universitas Tadulako. Bapak Ibu para hadirin, sambutan pertama akan disampaikan oleh Dekan Fakultas Kedokteran Universitas Tadulako, Dr. M. Sabir, Magister Sains. Waktu dan tempat kami persilahkan.
Okay, thank you, Dr. Rika Marnawalanda. Bismillahirrahmanirrahim. Honorable Rector of Tadulako University, and this event represented by Professor Amar Akbar Ali, Vice Rector of Cooperation and Development, Tadulako University. Welcome, Prof. Amar. Honorable of all of the speakers, Honorable of Head of Kagama Central Sulawesi Branch, Honorable Head of Provincial Health Services Central Sulawesi or representative, Honorable of Head of District Health Services Palu City or representative, Head of Indonesian Doctor Association Provincial and Palu City Central Sulawesi, Head of BPJS Palu City, Head of BPJS Luwu City, Head of Arsada Provincial Central Sulawesi, Head of Persi Central Sulawesi, Honorable of Dean of Faculty of Public Health Tadulako University, Honorable of all Director of Undata Hospital, Anutapura Hospital, Madani Hospital, Kabelota Hospital, Torabelo Hospital, Tadulako Hospital, Woodward Hospital, Budi Agung Hospital, Samaritan Hospital, Bayangkara Hospital, Dr. Sindu Trisno Hospital, and Sis Aljufri Hospital. Welcome to join to this seminar. Honorable Director Akbid Chandrawasi, Honorable Director of Akbid Grahananda, Honorable Director of Poltekkes Kemenkes Palu, Head of Stikes Widya Nusantara, Head of Stik Indonesia Jaya, and especially Head of Kagama, Central Sulawesi Branch, Gadjah Pranowo. Welcome to join to this event. And all participants, lecturer, clinical supervisor at the hospital, member collaboration with Faculty of Medicine, all student of medical Tadulako University, at the same time join to this event. First of all, let's pray and thanks to our God, who has given us His mercies and His blessing us until we can attend to the seminar without any obstacle, happy place and time. Secondly, my salawat and salam be with our Prophet Muhammad Sallallahu Alaihi Wasallam, who has guided us from darkness to the brightness in this world by Islam. Thirdly, I never forget to say thanks very much to the chairman of Kagama, Bapak Gadjah Pranowo, and thanks to all of the committee, Palu International Virtual Conference on Medical and Health Sciences, Dr. Putu Melaya, and all of the team that have worked together and spent of time to prepare this event. Ladies and gentlemen, in this conference, we have 4 speakers from abroad. For first session, the speaker from University of Iowa, Carver College of Medicine, Professor Mark A. Greber. Welcome to International.
Thank you.
Second session from Thailand, Professor Supasit Pannarutai, Faculty of Medicine, Naresuan University, with topic health system development in changing disease pattern in Southeast Asia. Welcome, join. And third session from Malaysia, Professor Dato Dr. Syed Muhammad Junid, University Kebangsaan Malaysia. Thank you very much for joining with topic healthcare cost management in Malaysia. And the fourth session from Gadjah Mada University, Professor Dr. Laksono Trisnantoro, Faculty of Medicine, Public Health and Nursing, with topic health insurance policy. I think we will get more information about this topic from all of the speakers, and we hope benefit of this seminar should improvement of the quality of health services system in Indonesia, especially in Central Sulawesi, improvement the quality of professional healthcare staff, improvement synergic coordination between healthcare staff, and improvement for lecturer, for student, for researcher interest in medical and health sciences, and including publication research in this field area. Therefore, you remain joining this seminar until the end. I would like to express my appreciation to the all committee who generously helped make this seminar come true. We could not have done it without you. Well, I do not want to take too much of your time. I need to hand over it to Mrs. Dr. Rika Marina Walanda, our today MC. And I would like to say once more on behalf of the seminar organizer, welcome. It is great to see so many of you here. And the last but not least, once again, thanks very much to all the support, to all the participants, to all the committee, and to all of my students that joining to this event. Thank you for your kind attention, and see you later in the next seminar. Assalamualaikum warahmatullahi wabarakatuh.
Salam.
Thank you very much to Dr. Sabir. Ladies and gentlemen, the next speech will be delivered by the Rector of Universitas Tadulako. In this case, will be represented by the Vice Rector for Development and Cooperation. Bapak, Ibu, Saudara-saudari, sambutan selanjutnya sekaligus membuka acara akan disampaikan oleh Rektor Universitas Tadulako yang diwakili oleh Wakil Rektor Bidang Pengembangan dan Kerjasama kepada Profesor Dr. Insinyur Amar Sarjana Teknik, Magister Teknik. Kami persilahkan, Prof.
The sound is good?
Good.
Yeah, we can
Iya, Prof.
Thank you. Before I begin the speech, I would like to convey the best regard from the Chancellor of Tadulako University and apology for him for not being able to attend this moment because there is another agenda and represents me. Assalamualaikum warahmatullahi wabarakatuh and good morning. All the greeting kindness to all of us and welcome to our international conference today. Honorable Head of the Central Sulawesi Provincial Health Office, Head of Palu City Health Office, Head of Health Social Insurance Administration Organization BPJS Palu Branch, Head of Health Social Insurance Administration Organization BPJS Lubuk Branch, Chairman of Regional Hospital Association SADA Central Sulawesi Province, Chairman of Indonesian Hospital Association Central Sulawesi Province, all directors, Director of Akbid Cendrawasih Palu, Director Akbid Geraha Ananda Palu, Director of Poltekkes Kemenkes Palu, Chairman of STIKes Widya Nusantara Palu, Chairman of STIK Indonesia Jaya Palu, Director of Poltekkes Kemenkes Palu, Dean of Faculty of Medicine Tadulako University, Dr. Muhammad Sabir SI, all deans and vice deans, conference chairman, Dr. Putu Melaya MPH, chairman and all management of the Gadjah Mada University alumni family, Central Sulawesi branch, all medicine department, all study program coordinator, and all lecturer and all activity academic and medicine faculty Tadulako University. Excellency, the keynote speaker on this Palu International Virtual Conference on Medical and Health Science PISA-ISI MH2 2020 today, Professor Mark Graber from University of Iowa, Carver College of Medicine, United States of America, Professor Dr. Syed Muhammad Al-Junid from University Kebangsaan Malaysia, Professor Dr. Supasit Panaruthai from Faculty of Medicine, Narasiwan University, Thailand, Professor Dr. Laksono Krisnantoro, MSc PhD from Faculty of Medicine, Public Health and Nursing, Gadjah Mada University, Indonesia. Distinguished guests, all the organizing committee and participants in Palu International Virtual Conference on Medical Health and Science 2020 from Tadulako University and the other university that I highly appreciate and welcome to International Virtual Conference today. Ladies and gentlemen, first of all, let's pray and thanks to Allah Subhanahu wa Ta'ala, who has been giving us some mercies and blessing so we can attend and gather in this virtual conference in good condition and happy situation. My salawat and salam are always given to our Prophet Muhammad sallallahu alaihi wasallam, who has taught their people respectively in order to attain happy and prosperous life in this world and hereafter. It is my pleasure to welcome the keynote speaker to deliver knowledge and share their experience in the topic of bio-national healthcare system in Indonesia toward university coverage 2020. This conference is proudly organized by Gadjah Mada University alumni family, Central Sulawesi Compartment, in collaboration with Faculty of Medicine, Tadulako University. I appreciate the effort conducted by Faculty of Medicine. Ladies and gentlemen, currently, Faculty of Medicine at Tadulako University is in an atmosphere of a different educational climate than its previous year. This difference is very noticeable in the learning process or teaching and learning activities that require of to use an online system. Even so, academic condition must continue to create both by teacher and learner. In this case, our student that we love. Our university throughout the world are not expecting Indonesia is feeling the effect of the coronavirus disease pandemic, but it doesn't preclude an activity that has been professional planned. One of them, of which the Palu International Virtual Conference on Medical Health Science 2020 that are taking place here today. Tadulako University is a university with vision to become international standard university in the development of environmental science and technology. There are several aims holding this conference are how to improve professionality of the healthcare service, especially in the field of medicine. The second is a media for coaching and development healthcare staff competence in their role in facing university coverage 2020. The third, comparing how the system in the development countries and Indonesia in facing university coverage. And the last, creating a work synergy and interpersonal between healthcare staff. In addition, the benefit that are expected from the conference are how to improve of health service system in Indonesia, especially in the Central Sulawesi, and how to improve to professional healthcare staff quality. The third, the improvement of synergy coordination between healthcare staff in Central Sulawesi, and finally, improvement of the lecturer, student, and researchers' interest the research publication. We also hope that this conference can be motivation for the research and sciences to develop research network and other corporation in the field of medicine, both in the outside the country, and they can publish their ideas in the research in international forum. Last but not least, this phenomenon become a very important basis theme of the International Virtual Conference this moment. I hope that with the presence of variable present in their respective file can broaden on our side how to improve and enriching about the beyond national healthcare system in Indonesia toward universal coverage in the digital era, especially in the era of the COVID pandemic. Ladies and gentlemen, finally, and on behalf of Rector Tadulako University, and the name of Allah Subhanahu wa Ta'ala, by saying Bismillahirrahmanirrahim, I open officially this Palu International Virtual Conference on Medical and Health Science 2020. And congratulations to you all to gain the much knowledge as you can today Virtual International Conference. Thank you very much for your kind attention. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you very much to Professor Dr. Insinyur Amar, Sarjana Teknik Magister Teknik. Ladies and gentlemen, we will now enter our last agenda for the opening session today. Ladies and gentlemen, we will hear and listen to Kagama's hymn. And with that, ladies and gentlemen, that is the final agenda for this opening session. Ladies and gentlemen, without further ado, we shall now begin our main event, which are presentations from our honored speakers and also a Q&A session. The session will be led by our moderator. Acara beralih pada pemaparan materi oleh panelis sekaligus diskusi tanya-jawab yang dipandu secara langsung oleh Dr. Indah Puspasari Kiai Demak, Master of Medical Education. Beliau merupakan staf pendidik di Fakultas Kedokteran Universitas Tadulako. Kepada Dr. Indah kami persilahkan.
Before, I apologize to have mapping leave the room because the other. Thank you very much.
Okay. Terima kasih Prof. Amar. Thank you so much for your attendance.
Thank you.
Thank you Prof. Amar. Thank you. Assalamualaikum warahmatullahi wabarakatuh. And good morning, ladies and gentlemen, and beloved students. I am Indah from the Faculty of Medicine, Tadulako University. I will be your moderator for this plenary session. In this session, we will have Prof. Graber and Prof. Supasit, each at about 30 minutes. And after that, we will have 15 minutes for discussion. Participants who want to ask questions, please write it at the chat box. The first speaker is Professor Mark A. Graber, Medical Doctor, Master of Science in Health Ethics, Fellow of the American College of Emergency Medicine. Dr. Graber is a professor of emergency and family medicine at the University of Iowa. He graduated from Eastern Virginia Medical School in 1981 and he completed an internship at Mary Imogen Bassett Hospital and then practiced in Wyoming for the National Health Service Corps. Being somewhat burned out, he took 2 years away from medicine to work as a computer programmer and help raise his children. As a late bloomer, he finished his residency in 1994 and has been teaching and practicing at the University of Iowa for the last 27 years. He is a Fulbright scholar, the author of 2 medical textbooks and numerous articles, and has received teaching awards both locally and internationally. In 2014, he completed a Master of Science in the Healthcare Ethics. Now he is the chair of the State of Iowa Pharmacy and Therapeutics Committee. His research interests are medical ethics and medical decision making. I would like you to welcome our first speaker. Please, Professor Graeber.
Terima kasih. Selamat pagi.
Selamat pagi, Professor.
So I'm going to share my desktop. Can you see my slides or not?
Not yet, Professor.
Let me try one more time. Can you run my slides? I don't know if I'm going to be able to run the slides.
Okay.
Let me try one more thing.
Yeah.
I think maybe you'll have to run the slides. Not allowing screen sharing.
Oh, not allowing screen sharing, maybe. Oh, you can share your screen now, Professor. Or would you like us to screen share your presentation file?
I think maybe, yeah. So I'll just have to make sure we're. Okay. So my name is Mark Graeber. I'm from the University of Iowa. Now I can do it, I think. Nope, I think I'll have to run off your slides. So I'm Mark Graeber from the University of Iowa. Thank you very much for this opportunity. Next slide, please. Next slide. Yeah, so I was asked to speak about family medicine, and every culture is going to have a different concept and implementation of family medicine. So what I'm presenting is what we do in the United States. And so the model might be a little bit different for Indonesia. So those of you who don't know me, I've been back and forth to Indonesia for the last 10 or 12 years, doing some teaching, especially at Gadjah Mada University in Erlangga, but also in Sumatra and Timor and elsewhere. So over the number of years, I've developed some ideas that I think might be helpful, that both in America and also in Indonesia. Okay, next slide. So one thing that's important to understand is that simply providing universal care without increased training doesn't work. So this was a study that was published out of Britain in Lancet, and basically they looked at providing universal care for everybody versus providing universal care with and what additional training might be useful in terms of patients' health. And what they found out was that 21% of mortality in patients under 75 for men and 30% of mortality for women was amenable to good quality health care. So simply providing health care isn't adequate. And certainly in the United States, up until maybe 15 or 20 years ago, people would just go to 1 year of internship and then practice. But what the research has told us is that additional training is really important to improve the health care of the population, not just universal access, but universal access to higher quality care. Next slide. And this is another study that was published not too long ago, 2005, and they looked at increasing populations of specialists within the population versus increasing the number of primary care doctors. And when they looked at the health disparities and mortality rates, simply increasing the number of specialists didn't seem to impact that. But if you increase the number of well-trained primary care doctors, the health benefits were pretty evident. Patients' health status got better. The differences between urban and rural got better, because certainly in the United States, it's a problem. And I know it's also a problem in Indonesia that doctors like to live in the cities. And unfortunately, a lot of the patients aren't living in cities. So having primary care doctors in the community that are willing to go to rural areas and are trained specifically for that improve health outcomes. Next slide. So just a little bit about the University of Iowa. We're the largest university-owned hospital in America. We have over 1,000 inpatient beds, and we have residencies in pretty much everything that you would ever want to study: family medicine, internal medicine, pediatric orthopedics, etc. Next slide. So we're located pretty much right in the middle of America. Unfortunately, the pictures that I sent aren't going to be able to be shown because the files were too large, but Iowa is pretty much agricultural. Most of our workers work in corn production or soybean production or egg production, chicken farming. So it's very much similar to a lot of the parts of Indonesia, in that most of our cities are very small, less than 5,000 people, and our cities are far apart from one another, similar to an island in Indonesia that might be far away from a major medical center. So we're actually the major medical center for most of Iowa, as well as parts of some of the other states, just because it is very rural and very agricultural. So we don't have a lot of specialists and we don't have a lot of population, similar to might be in the islands in Indonesia, where it's a smaller population. Next slide. So this is a slide that looks at what family doctors do. So basically, family doctors in the United States require 3 additional years of training, and we'll talk a little bit about what that training consists of in just a second. But most family doctors perform the wide range of services, including taking care of adolescents, infants and children, a lot of chronic care management, so a lot of care of the elderly, a lot of geriatric medicine, so a lot of not only chronic care management, so hypertension and diabetes, but specifically focused on the elderly. About 77% of doctors do that in family medicine. So you can see that the services that we're able to offer in our office are pretty wide. About 36% of family doctors do inpatient care as well. So that's not as common as it used to be. It used to be that most family doctors saw their own patients, but medicine's getting complicated enough and doctors are so busy enough that hospitalized patients in the United States are frequently seen by another doctor and not their family doctor. Okay, next slide. So what makes family practice different from other specialties? I think that's the main question I'm trying to answer here today. And we'll talk a little about the training. First is that we use what's called a biopsychosocial model. Most specialties, for example, surgery, cardiology, renal, gastroenterology, use a biomedical model. So they're focused only on the medical aspects. They're focused just on the blood pressure. They're focused just on the blood sugar. They're focused just on oncology treatment or something of that sort, focused only on the angina, focused only on the heart failure. Whereas with family medicine, we try to look at the whole person. And if you look at specialty care, a lot of time patient satisfaction is pretty low. They're not really happy because their doctor isn't really listening to them. They're too focused on just the illness. Next slide. So most primary care uses the biopsychosocial model. Primary care pediatrics, family medicine, some of the internal medicine doctors. And let's look at some examples. Next slide, please. So for example, if you go in to see a cardiologist or if you go in to see an internal medicine, they're going to focus on the biological aspect. They're going to focus on the diabetes. They're going to say the blood sugar's high, let's lower the blood sugar. But that's not all that we need to take care of when we're taking care of diabetes. We need to take care of the person and what the psychological aspects of their disease are. Am I speaking too quickly or okay?
No, it's all right, Professor. We can understand you.
Okay. So most doctors will look only at the biological model. So for diabetes, that would be elevated sugar and lowering the blood sugar. But we also need to take care of the psychological aspects. So when you tell a patient they have diabetes, that can lead to depression. They are things that they may not be able to do. They may not be able to work at the job they like. They may not be able to eat the foods that they are used to. They may not have the proper education to understand their illness. So not only do we need to give them a pill, but we also need to make sure that they understand their illness, what they can eat, what they can't eat, why that's important. Are they depressed about having diabetes? And then we also need to look at the social, so biopsychosocial. The social aspect of illness is also very important. So for example, you can raise your hands at home. I know I can't see you raise your hands, but you can raise your hands if you'd like. So for example, how many people out there does the husband cook all of the meals? You can raise your hand. Not very many people. So if we just talk to the patient may want to keep eating fried food unless we talk to the person who's making the meals, who in Indonesia I know is mostly the women. It's also mostly the women in the United States. But unless we talk to the family and talk to the wife, nothing's going to change because, I mean, I'm male, but males don't like to follow instructions, right? So we really need to involve the whole family. Who's going to help them meet their goal? Who's going to be cooking the food? Also, how does the illness affect the community? Maybe the patient can no longer work because of diabetes complications. How does it affect the family? How does it affect the community? Are they going to be able to afford their medicines? Do they have social support? Is there family around that can help the patient meet their glucose goals or what other goals they might have? So we need to look at not only the biological aspects of disease, but we have to look at the personal aspects, the psychological aspects of disease, and then also the social aspects. How does it affect the family? How does it affect the community? Next slide, please. Another example, for example, in pediatrics, the biologic aspect is infant colic. What causes, I'm sorry? The biologic aspect might be infant colic, where the child's screaming and screaming and screaming. And the question we might ask is what causes colic and what can the parents do? But any of you who have had a screaming baby know that it's really stressful. And so we need to not only ask the question, what can we do for the baby, but is the mother feeling stressed out? Is the mother feeling depressed? Does she have postpartum depression? Does she have guilt about the baby crying all the time? Does the mother or father feel like they failed because the baby's crying all the time? And how does it affect the rest of the children in the family if the parents can pay attention only to the one child? So we need to look at the biological, but also the psychological, the effect of the disease on the parents. And then we need to look at the social as well. Is there any risk of abuse or stress? Are there supportive people in the community that can give the parents a rest if the child's been crying for hours and hours? Is there an extended family that the child can go stay with if the parents need a break from the crying infant? So we need to look at not only the biologic, the fact that the kid has colic, but we also need to look at the psychologic. How's it affecting the mother? Does there postpartum depression? Does the mother or the father feel bad, like they failed? And then is there some other social aspect that we can help with? Somebody that can watch the child if the child needs help or the parents need a break. Next slide. So a lot of it is family reaction to stress and disease, loss of income, loss of independence. The family might be not happy because they're not happy having to take care of somebody. And then there's also a societal reaction to disease. So people are treated differently if they have HIV or cancer or something like that. A lot of people won't interact with those people the same way. And so we need to look at how society is affecting the patient as well and how we're reacting to our patients. Next slide. So that's the biopsychosocial model. Look at the biologic aspects of the disease. Also look at the psychological aspects. How is it affecting the patient? Also look at the social aspects. How is it affecting the community or the family? The second concept that's important in family medicine, if you can go back, is the concept of a medical home. And a medical home is a place where the patient can coordinate all of his or her care. So what we're trying to do is have a doctor or other provider that has an overall view of the patient and knows exactly what's going on with the patient. Next slide. So the patient who sees a lot of specialists, next slide, ends up with a lot of medications, and one doctor may not talk to the other doctor, so they get two different medicines for their blood pressure, or they get medicines that cause interactions. Next slide. And so eventually with an elderly person, if they're seeing many doctors, they can end up being sick just from the medications or from the side effects. So the concept of a medical home, one doctor or one provider that knows everything that's going on with the patient and can coordinate all of that. So for example, every time a patient comes in to see us in the clinic, we ask them for a list of all of their medicines. Even if they're getting the medicine from a different doctor, even if it's from an over-the-counter medicine, that way we're able to check the medicines and make sure there aren't duplications. They're not getting 2 blood pressure medicines, 2 antidepressants, that sort of thing. Because if they're seeing 5 different specialists, they may end up on 5 different medications for the same problem, all of which can interact. So the concept of a medical home is important in family medicine. Next slide. So a little bit about family medicine training. Basically with family medicine, we have 3 years of postgraduate training. So in America, we go to college for 4 years, and then we go to medical school for 4 years, so 8 years. And then we do at least 3 years of postgraduate training. So family medicine has the same training as other specialties, like internal medicine is 3 years, pediatrics is 3 years, anesthesia is 3 years, and family medicine is 3 years. And if anybody's interested in looking at the curriculum, I put the curriculum link there. So it's standardized over all of the country for all family medicine residents, get the same curriculum. And I didn't think talking about it in detail would be all that useful, but you can pick up the the link if you're interested in some of the specifics. Next slide. So this is a little bit of what we study, not in a lot of detail, but in the first year, we have basically 8 weeks of inpatient medicine, 4 weeks of obstetrics, 8 weeks of pediatrics, both in the clinic and the emergency department, internal medicine, some time in the ICU and cardiology intensive cares, orthopedics, urology, ophthalmology, and then of course everybody gets some vacation anyway. So that would be what we study in the first year. Next slide. The second year builds on that. We get 4 weeks in pediatric emergency medicine. We get more family practice inpatient care, obstetrics, cardiology. I'm not going to read them all because you can look at them there, but basically we also have about 4 weeks of electives. So if you're particularly interested in orthopedics, you can do an extra 4 weeks of orthopedics or an extra 4 weeks of GI or pediatric neurology, whatever elective you would like. And next slide. And then the third year is basically builds on the same thing. You get more electives, 10 weeks of electives, procedures, neurology, more pediatrics, more clinic time as well. Also some community mental health. So you can see that this would help you be well trained to take care of somebody in a rural area that has a small population. For example, most of the United States, the cities are relatively small, and there may not be specialists in the area, which I'm sure is true in Indonesia as well. And so the question I usually ask people when they're talking about family medicine is, would you rather have your grandmother taken care of by a doctor with 1 year of training or by a doctor with 3 years of training? And you can see the 3 years of training are pretty intensive. So they teach you to take care of a lot of problems. Next slide. One thing that's really important that we do in family medicine is that we have specific training and communication skills. So we learn how to give bad news. We learn how to hold family meetings. We learn how to deal with the angry patient. We learn how to deal with the patient that's not taking their medicines. We learn how to set an agenda with the patient, how to determine what we're going to talk about during the visit. So communication is really important. And so there's a full curriculum available online. I think my email is on the last slide. If you send me your email, I'll send you a link to the communication curriculum, which is free. And you can get that online, because it's really, empathy, end of life care. How do we deliver bad news? How do we make decisions with patients? All of those are topics, and it's not something that you just learn automatically. You can actually teach people to be good listeners, and you can teach people to be good communicators. And so that's part of the goal of family medicine. Next slide. Residency training is competency-based. Next slide. And so what this means is that if any of you go online and look at our curriculum, you have to take care of maybe 10 patients with heart failure during your residency. You have to take care of 10 patients with COPD during your residency. And after you take care of those 10 patients, you cannot demonstrate that you know what you're doing. You have to do it again. And you have to do it again until you can demonstrate that you've mastered how to take care of all of those problems. So it's just not 3 years sitting in a hospital. You have to prove that you've mastered how to take care of these illnesses. And so it's really, it's a performance-based residency. It isn't just spending your time. You actually have to demonstrate that you learn. Next slide. One thing that's important is that the professors or the teacher has to hear about every patient seen by the resident. So this is fairly labor intensive, especially in the first year, when we have to hear about every single patient before they can let the patient go. but that's how the teaching goes. And that's how we know whether the students are learning. Because if they can come to us and say, Dr. Graber, I've got a patient with heart failure who also has COPD, who also has diabetes. Here's my plan for the patient. These are the medicines I'm going to do. These are the medicines I'm going to stop, because stopping medicine is just important sometimes. And then we can say, okay, yeah, I approve that plan. Go ahead and do that. That way, not only are we sure that the patient is going to be safe after being seen by the resident, but we can also show that the student has mastered the problem. Next slide. One thing that's really important is that none of us know everything. And the longer I am in medicine, I realize I know less and less. So we really need to be able to look things up. And so one of the important skills that we teach our students is how to ask appropriate questions. Next slide.
Professor, I'm sorry, you 5 minutes left. You have 5 minutes
Yep.
left.
So there's two types of questions. There's disease-oriented evidence and there's patient-oriented evidence. So mostly if you see studies, they say this drug is really good because the hemoglobin A1C went down by 0.5%. But we really don't care about that. What we care about is how did the patient do? So when we're asking questions, we shouldn't ask, is the blood pressure lower? Is the hemoglobin A1C lower? Is the FEV1 better? What we need to ask is, how is the patient doing? Do they have fewer cardiac symptoms? Do they have fewer hospitalizations for pulmonary symptoms? Were there fewer strokes? So those are patient-oriented evidence. Next slide. And I will finish in my 5 minutes. There's a lot of evidence-based medicine resources that you can find online that teach you how to ask a question. Next slide. Next slide. You can look those up if you're interested. Basically, we teach our residents and doctors how to frame a question. So it's called PICO, P-I-C-O in English. What's the problem? What is the intervention? What is the comparison? Is it placebos or another drug? And what's the outcome of interest? Next slide. And these are some PICO questions directly from Oxford University. Patients with recurrent infection, intervention, prophylactic antibiotics. What's the comparison? No treatment or treatment. And then what's the outcome we're interested in? Next slide. And just another PICO question. In this case, is having a vasectomy increase the risk of prostate cancer or testicular cancer? The population is adult men, intervention vasectomy, comparator no vasectomy, and our outcome that we're interested in is testicular cancer. Next slide. And next slide. So the rest of the slides are basically references that talk about how health is improved in patients with family doctors, how outcomes are actually improved. It's, as we talked about during the training, it's really an outcomes-based residency. We have to show competence. And so I think there are 7 or 8 references after this that we can discuss if we have time later. But the bottom line is that not only is this good in theory, but there's really good data to support that family medicine training improves health outcomes. And that's really what we're interested in. We're not interested in training doctors just to train them. We're interested in health outcomes. And I will end it there, but all those references are there for you that you can look at. There's improved mortality, there's fewer visits because patients are taken better care of, there are fewer surgeries, there's better cancer outcome. And so training really makes a difference, and that's what the rest of the slides say. But I think the points that I made are the important ones in terms of what we do with our training. So thank you very much, and I'll turn it over to the next speaker.
Thank you, Professor Graber. Now let's move to the second speaker. Professor Dr. Supasit Panarunotai, Medical Doctor and Doctor of Philosophy. Professor Supasit is currently Chair of Center for Health Equity Monitoring, an independent organization undertaking research on health system and policy. He earned his Doctor of Medicine degree from Faculty of Medicine, Ramati Body Hospital, Mahidol University, his Master of Science from National University of Singapore, and Doctor of Philosophy from London School of Hygiene and Tropical Medicine. Having worked as a surgeon and community physician at a regional hospital for over 10 years, he then worked at the Ministry of Public Health as a health planner and researcher. His main research focuses have been on healthcare financing, cash mix systems, and universal health coverage. He joined the Faculty of Medicine, Narasuen University in 1998, earned professorship of community medicine, then served as dean of the faculty for 9 years. After retirement, he is still active in researching for health equity and paying for health and social services in Thailand. I would like you to welcome our second speaker, please, Professor Supasit.
Hello, thank you very much, Dr. Inda, for the introduction. Have I shared my slides?
Yeah, you can share your slides.
Can you see it now?
Not yet, Professor.
Not yet.
Oh, yeah.
Yeah. Okay. Thank you for inviting me to join this virtual conference. So I focus on the health system development in a changing disease pattern in Southeast Asia. Okay, so I will touch upon the changing disease pattern, which mostly from the OECD paper publication on that, on the health system development and what's beyond the universal coverage. As we all know that disease patterns very much related to demography and determinants of disease, and this will reflect on the pattern of disease itself. So most of the slides are taken from the OECD WHO 2018 publications, Health at a Glance, which compare several countries in the Asia and the Pacifics. I just highlight some of the, with the color here, the Thailand and Indonesia, and you can see the rest from the slides or from the reference. So we can see that the share of the population of the age, aging 65 years and over and 80 years and over, with the changing from 2015 to 2050. So there'll be much more proportions of elderly people in Thailand as compared to the Indonesia, and also for people aged than 80 years old, in males and females. You can see much more of the older persons. The other aspect of that related to health is the proportion of population with overweight or obese. The changes from 2010 and 2016 can compare between males and females. The number of people with the overweight and obese, you can see that there will be an increase of that. Indonesia a little bit bigger, higher than Thailand is somewhat higher than Indonesia. Looking at the smoking, so you can see that the rate of smoking in male is much more than female, but unfortunately the rate of smoking in Indonesia by the slides is much higher than other countries. For alcohol consumption, which related to pattern of disease, you can see that Thailand is on the top of this slide, this graph, comparing with other countries. Now, related to alcohol is it affects the road traffic injury and death, and it's unfortunately Thailand ranked the first in the world, or in these slides, that we had road traffic death the highest, and a higher proportion is related to alcohol. Diabetes, as the result from the obesity and some inactivity in our life. Yes, we can see the increase of the rate of diabetes compared between the years of 2000 and 2015, and the prevalence in male and female. So in Thailand is a little bit higher than in Indonesia. This more or less may be related to the rate of obesity, which presented in the earlier slides. And looking at some of the disease, HIV, which happened almost about 40 years ago that we discovered. Thailand, it's in this slide, Thailand has the highest prevalence rate in the HIV. And but if we see the size of the populations, because of the size of the population of Indonesia is much higher than in Thailand. Indonesia, you have 200 million population. So even the lower prevalence, you have a much more number of people with the HIV. But if you compare to India, it's very much higher. Because of the HIV, if we learned the HIV disease, HIV had developed. They tried to develop vaccine, but it's not successful. But the treatment for HIV and AIDS, it's very dramatic, successful. So the access to medicine is very crucial in terms of reducing the transmission of disease. And Thailand, by the slides, the access to care, to the treatment of HIV and AIDS, it's very good. This is because of the universal coverage. But in these slides, you can see Cambodia, it's even higher. That's perhaps because of the external assistance from many countries around the world. And if we see result of the access to care, then the incidence of the new case is very important for the describing the pattern of disease. So these are a few of the changing of patterns of disease in our region. So what can we discuss next about the health system development in response to that disease patterns, focusing on the supply sides and utilizations of health system, the disparity and the quality and the relationships between the health outcomes and the health infrastructure. Human resources, as Professor Mark Graeber discussed about the family physician is very important. But by these slides, it's take account of all of the doctors and all of the nurses compare with in the Asia Pacific regions. And we see that the number of doctors per populations, number of nurses per population, 1,000 population, number of doctors per 1,000 population. See that in Thailand and Indonesia, we have pretty close in the positions, but the number may be different. But for the nurses, the number of nurses per 1,000 population in Thailand, it's quite higher than in the Indonesia. So the proportion of doctors and nurses in several countries are also important description of the health system, that how we allocate the work between doctors and nurses. Looking at some aspect of human mental health or the psychiatric care, which can be a ballooning problem to our health system. Psychiatrists, there are much difference between Thailand and Indonesia in terms of psychiatric doctors and also nurses working in the mental health field. If you look at the scatter plot that many publications internationally, they try to make some of the relationships between X and Y. For these slides, the bed supply and utilization. For the X-axis, the hospital beds per 1,000 populations. You can see wide variations here. Like if in the rich countries like Japan and Korea, they have many beds per 1,000 populations. But we are around here, like in Thailand, we had around 2 beds per 1,000 populations. But if we compare with the hospital discharge per 1,000 population, they're quite increasing relationship. But if we see the R-square is about 0.2. That is not very high. That means the supply side of hospital beds may have some influence on the hospital discharge. That means utilizations of the hospital beds may vary among countries within the Asia Pacific region. and the disparity of access to healthcare. Disparity that's within each country. We can see the difference of the access to care by education level, the lower education people and the higher educated people. So, or we can compare the access to care between rural area and the people in urban area, people in the low income family and the high income family. You can see like in Laos here, it's very much difference, high disparity of the percentage of the birth attendance by skilled birth attendance by education and by income wider than the rural and urban area. So this is quite interesting that in terms of disparity, we have to be aware of the education and the income of the population within the same community. There can be wide, big variations. But in Thailand, you can see the for this, it's quite good that we can reach a high percentage of access to skilled birth attendance, and its disparity, it's quite small. But in terms of quality of health system in response to the health needs or pattern of disease, as we know that we are facing with the non-communicable disease because of aging and because of other environment and many other issues. This is the comparisons of survival of the breast cancer patients, Thailand compared to other countries. Yeah. So Thailand, it's doing a little bit better than Malaysia here, just Penang, in Penang only. So about two-thirds of survival as compared to the well-advanced country like Australia and Japan. But we are even worse. We are the worst in these slides in providing quality for cervical cancer care. For the relationship between health system and outcomes, this is the maternal mortality. If we look at the R square, which I want to highlight, the R square. The R square here, the highest in these three slides, the highest is for the birth attended by skilled personnel and the maternal mortality ratio. That means if we have good obstetric care, birth attended by skilled personnel, the maternal mortality ratio will be much reduced. This is relationship is better than the antenatal care coverage or the number of low birth rates. Finally, we prefer, it's much agreeable to conclude that even though we try to build up our health system, but the dominant issues of health and wealth is quite strong here. The R square is 0.66, but we may have some exceptions that within the same like here, Vietnam, within the same GDP per capita, Vietnam has achieved the very high life expectancy. So within this, we have to learn more about the health system among the low-income countries here, or the middle-income countries here. Then, which country have the best layout of a health system and health seeking? So beyond the universal coverage, what are the government contributions to health system, and what's the USC universal health coverage progress and the response to COVID-19? These slides show the coverage, the percentage of coverage for different kind of services, family planning. We have variety of variations of the coverage of family planning, but for the antenatal care, we have quite good coverage for all all the countries. It's skewed to reaching 100%. But looking at the antiretroviral therapy, as I highlight in the HIV, so there are much high variations in access to care. So this reflects what are the cost-effective intervention and the universal coverage of the contribution of each countries, or international assistance like in Cambodia in the previous slides. So there are also the change within the role of the government for the universal coverage. They divided into the increasing in the expenditure for health as a percentage of GDP. Thailand is increased a little bit, but Indonesia, as compared to the GDP, so it's quite decreasing a little bit. For the percentage of government expenditure as compared to the to health from the total government expenditure, Indonesia is quite increased. But why this is decreased? But perhaps the taxation capacity of Indonesia government increased, but the spending of the government to health rather decreased. So this is what we can learn from the contribution of the government in relation to the universal coverage. So the health systems and the SDG, we are now moving to the SDG, and the universal coverage is at the center of trying to reach for the equitable or reducing disparity, increasing the outcomes of health and well-being. And another publications of the OECD, which tackling the wasteful spending on health, is quite interesting. That the waste in our health system, is it unintentional or is it the deliberate? That means we know that we are wasting, but we are not making any improvement. We just neglect them. So there are many level of waste as the regulators or at the patient level. So if we study about this, we can reach the more better health system. So finally, in the statistics, some statistics about COVID-19, just a few days ago, we have almost 50 million of the infections. And within our regions, we have wide variations. In Laos, we have only 24 cases, but the highest in our regions is still in Indonesia, because we have Indonesia has largest populations, but in the Philippines, yeah, the second is in the Philippines. So what can we relate the GHS, or the Global Health Security Index, published by the Johns Hopkins a year before the COVID-19. This is quite interesting that are there any relationship between the GHS index with the COVID-19 index, that the health system can respond to the pandemic or infectious disease. So in summary, changing disease patterns, demographic changes, and determinants of health are related. And the supply side of the health system may have relationship with the utilizations and the health outcomes, but in different R-square, yeah, with different shades of relationships. There are room for improvements in efficiency, also in equity and the quality of healthcare. The strong health systems are the foundations of an effective response to the COVID-19. So these are the messages that I would like to present this morning. Thank you very much. And sorry for my video that I cannot fix that. Thank you.
Thank you, Professor Supasit, for your wonderful and interesting talk. We have several questions from the chat box. We'll read it first. Then if we still have time, we will allow participants to ask directly to the speakers. Let me see first. There's a questions from Siti Anissa from Tadulako University for Professor Graeber. As a medical student, what should we be prepared to become a family doctor who can approach patients in bio, psycho, and social aspect?
Mm-hmm. So I think the answer is that every doctor should be using the biopsychosocial model. Whether you train to be a family doctor, whether you train to be a pediatrician, whether you train to be internal medicine, we need to take care of the whole patient and just not address only the illness. So I chose to study family medicine because I wanted to see children, I wanted to see adults. At one point I wanted to do obstetrics. I don't do that part anymore. But whatever you train to be as a doctor, the biopsychosocial model is still applicable. We need to treat our patients as people first and diseases as part of that. So I hope that answers the question.
Thank you, Professor Graeber. And this question is for Professor Supasit. You say in your presentation that Indonesia has to improve more for health equity and from your perspective, what are the improvements that Indonesia needs to make a better health system here?
Yeah, it's a very challenging questions, and I think these challenging questions exist for many years. Mm-hmm. But as Professor Graeber said, the training of the human resources for healthcare and the distribution of human resources, as it's very, very difficult to compare between Indonesia mm-hmm. and Thailand, because Indonesia, you have many islands. Yeah. So the situations are very challenging. But mm-hmm. If we believe that the good quality family medicine distribution mm-hmm. that will be achievable with the equity and also high quality of care. So I concur with the Professor Graeber and also Professor Barbara Starfield, who is a champion on this.
If I could add one thing, good healthcare does not mean that it has to be high tech. Good healthcare means taking care of basic diseases like hypertension, diabetes. It doesn't mean cardiac catheterizations or MRIs. Indonesia has 17,000 islands, which is a lot of coverage, but you don't need high tech to practice good medicine. You know, high tech is only the pinnacle, but the base is really primary care.
Yeah. Thank you, Professor Supasit and Professor Graeber. I think the time for the plenary session 1 is up, so we will close the first plenary session. Thank you very much for Professor Mark Graeber and Professor Supasit for your presentation and sharing about the topics.
If I could make one quick comment. I did try to answer all of the questions in the chat box. So anybody who asked a question, the answer should be in the chat box for you already.
Yeah, we have read the answer that you write in the chat box.
Yep, thank you.
Thank you very much. Please applause for both Professor Graeber and Professor Supasit.
So, thank you very much.
Thank you.
Thank you very much.
Okay, ladies and gentlemen, that was our first session. We'd like to thank you to all the speakers for the wonderful topics discussed in this first session. Now, ladies and gentlemen, we will continue on to the next session, which is the second session. Bapak Ibu, para peserta seminar, kita akan melanjutkan untuk sesi yang kedua. Sesi yang kedua ini akan diisi oleh 2 pemateri dan akan dipandu secara langsung oleh Dr. Indah Puspasari Kyai Demak, Master of Medical Science. Akan dilanjutkan oleh Dr. Indah. Terima kasih, Dr. Indah. Mohon kami persilahkan.
Thank you, Dr. Rika. Good morning and Assalamualaikum warahmatullahi wabarakatuh. Now we move to the second plenary session. In this session, we will have Professor Aljunied and Professor Laksono that will be our speaker. And after the presentation, we will have 15 minutes for discussion. Participants who wants to ask questions, please write it at the chat box. Okay. Our third speaker is Professor Dr. Syed Mohammed Aljunied bin Said Junid, Medical Doctor, Master of Science, Doctor of Philosophy, Diploma London School of Hygiene and Tropical Medicine, Fellow of the Academy of Medicine Malaysia, Fellow of Public Health Medicine Malaysia, and Fellow Academy of Science. Professor Aljunied is the first professor of health economics in Malaysia. He is the first Malaysian to obtain Doctor of Philosophy in Health Economics from London School of Hygiene and Tropical Medicine in 1995. He obtained his medical doctor from National University of Malaysia and Master of Science in Public Health from National University of Singapore. He is the founding head of International Center for Case Mix and Clinical Coding, a center of excellence on case mix and health economics research in Faculty of Medicine, Universitas Kebangsaan Malaysia, which was established in 2011. Prior to this, he served as a senior research fellow of United Nations University International Institute for Global Health from 2006 to 2014. Currently, he is appointed as the founding professor and chair of Health Policy and Management, Faculty of Public Health, Kuwait University from 2016. He is also the Director of Postgraduate Programs of Faculty of Public Health, Kuwait University. He is now appointed as a consultant and advisor on case mix systems at National Center for Health Information of Ministry of Health Kuwait. Let's welcome our third presenter, please, Professor Muhammad Al-Junid bin Said Junid.
Thank you, Madam Chairperson. Assalamualaikum warahmatullahi wabarakatuh. And very good morning to everyone. I would like to thank the organizing committee for inviting me to present a paper in this very important conference. And I was asked to talk about the healthcare cost management with special focus on Malaysia. And I will try my best if I can actually explain what is being done in Malaysia regarding the management of the resources. So Malaysia is actually a much smaller country compared to Indonesia. We have only about 10% of your population, just over 30 million people. We are located between islands of Indonesia. We have two parts of Malaysia, the Peninsular Malaysia and also the two of the states are in the Borneo Island. Our per capita GDP is just over 12,000 USD. Over the past few years, we have been having quite a GDP growth as high as nearly about 6%. But now with COVID-19, things has gone down pretty fast actually. Per capita expenditure is about 426 US dollar, and over the years, we are spending about 4% of our GDP. The health system in Malaysia is organized somehow into three different pillars. We have a very strong public health system, which is led by Ministry of Health, although other ministries are also involved, such as the Ministry of Education, taking care of the teaching university, teaching hospitals, Ministry of Defense, which run the military hospital and some local authorities. We have quite strong private for-profit organization, especially for the primary care services. Although the private hospital contributes only about 25% of the total base, but more than 70% of our primary care services are provided by the private sector. And then also we also have what we call the private not-for-profit organization, which help to organize and run certain special services such as cancer care, care for HIV, palliative care. Most of them are actually on voluntary basis. In terms of the contributions of primary healthcare, I've already mentioned that a lot of primary healthcare services is given by the general practitioners, but the maternal and child health at the primary care services are the domain of the public sector. And if you look at the situation in terms of the health indicators, we have a lot of improvement over the past 10 to 20 years since we achieved our independence 60 years ago from the British. You can see that most of the indicators has improved quite a lot, especially the infant mortality rate as well as the maternal mortality rate, which is one of the good thing that the government have done on giving the priority to maternal and child health services. So what have the government done right for the Malaysian health system? One of the success stories in terms of our achievement is, of course, the priority on the primary health care. The government provide a lot of infrastructure for primary health care services, and this is one of the reasons why we achieve universal health coverage since 1985. If you just look at the primary health care facilities that are provided by the government, and anybody can just go there to get the services at a very low cost. The government provide block funding, and they play a very major role. And the other important aspect is that the Malaysian government have supported quite a lot to the local universities to run the local specialist training program. Previously, we used to depend a lot to send people to mostly to UK, Australia, and also to a small number to US. But now most of the time, nearly about 80 to 85% of our specialists are trained locally. These are the major challenges that we are facing in the Malaysian health system now. We need to sustain our universal health coverage. There are still issues regarding the health financing. Malaysia is still using the conventional way of funding the services using taxation base. We have a number of times trying to introduce social health insurance, but it was not successful. There are issues regarding increasing in healthcare costs, raise in the prevalence of chronic diseases, and also risk factors such as obesity, high in the poor diet, and also lack of exercise. And the system between the public and the private sector are quite fragmented in the sense that there is very little interaction between the public and the private health sector, and that creates a certain amount of issues in our health system. If you look at the total health expenditure in Malaysia in terms of the amount of resources has gone up quite a lot. In 2017, 57 billion compared to probably about 10 years ago or nearly 20 years ago is about only 20% of that. In terms of per capita GDP, it ranged between 3 to 4%. The latest is about 4.2% of our GDP being spent on healthcare. The healthcare expenditure in terms of per capita has increased from just 700 ringgit in 1997 to now nearly about 3 or 4 times than before, which is about 1,800 ringgit. So the cost has been going up. If you look at the total expenditure as a percentage of GDP compared to many countries in the region, we are spending more or less between 3 to 4%, which is much smaller than what being spent by OECD countries. One of our main concerns in Malaysia is regarding our out-of-pocket expenditure. Since we do not have social health insurance, if people want to seek healthcare in the private health sector, they have to pay out of pocket. So now our the out-of-pocket expenditure contributes nearly 40% of the total health expenditure, and this is actually getting more and more difficult for Malaysia to seek healthcare in the private sector, and it might actually be one of the issues of inequity that we are concerned with. 52% of our funding come from a public sector, which is mainly from taxation. 60% of them are from direct taxation, and the other 48% are from a private source, mainly from out-of-pocket, which is 39%. We have a small contribution from the private insurance, which is just around less than 10%, about 7%. What are the costs of raising healthcare costs in Malaysia? We can divide this from the looking at the demand as well as the supply factors. In terms of demand factors, we know that aged population is a major problem in many countries. They suffer from mostly chronic non-communicable diseases, and costs of healthcare for the aged population are very high. There are also issues of availability in supply, which actually leads to increase in demand, socioeconomic problems, and also demand for the health insurance cover. From the supply side, the production cost of providing the services to cover the cost of doctors and specialists is getting higher. There were also issues regarding the type of coverage and the scope of services, which actually lead to the increase in healthcare costs. There are a lot of technological advance currently, and that is actually one of the important aspects where the capital investment is quite intensive, and this actually contribute to increasing healthcare costs. Increase in hospital bed and facilities do play important role, and at the same time, when the population are more and more educated, there are a lot of issues regarding the medical litigation, and doctors tend to practice defensive medicine, which actually leads to increasing in healthcare costs because they will be doing a lot of unnecessary tests and procedures to cover themselves from medical litigation. The other issues related to from the supply aspect, including the financial incentive and payment method. In private sector in Malaysia, people are still using fee for service. although in the government sector, the payment is by salary. So fee for service will be one important factor that might increase healthcare costs because it might lead to what we call the supply-induced demand. Medical frauds, to a certain extent, might occur, might be one important factor that might lead to increase in care costs, especially if they are being reimbursed by the insurance, especially in the private sector. So cost management and cost containment is an important aspect. It is a process of controlling the expenses that are required to operate an organization within a pre-planned budgetary constraint. The outcome of cost management and cost containment measures is hopefully to keep the cost down and also to meet the financial targets. We can divide the cost containment measures into two different types, looking at their impact and also the action that being taken by these methods. We have a direct control and indirect control. This is the direct control of cost containment. What I label in red are the one that being conducted in Malaysia, and the one which is not highlighted in red are the one that very little being done in Malaysia. For example, in Malaysia, most of the hospital in public sector, they were given budget, and there is a budget ceiling set by government. So for example, now we have a COVID-19. Many of the hospitals that are managing COVID-19, they do not have enough budget because the budget are set before the pandemic occurred. So they had to request for additional budget. So budget ceiling is one of the good way to control costs, but there are challenges faced by the hospital managers to manage the hospitals here. The limitation in the staff number is one of the other factor, but it is not being done that well. There is a limit in level of remuneration. So in Malaysia, the government facilities, the doctors are all being paid by salaries. So they do not have to actually, they are not paid according to the volume of work. This is good in terms of budget, but the negative thing about that is that when you pay by the salary, there's no incentive for one to work hard, and this actually lead to some other problem. For example, the waiting time might be longer in the government compared to the private sector. Since the private sector, the doctors are being paid by fee for service. There were control in terms of the hospital beds, and in terms of the provider payment, we use the salary scheme. This is different from Indonesia, where you use the case mix system, where the amount of resources being paid depend on, to a certain extent, on their workload and the type of cases that they see. In terms of medium term, the direct control include control of construction and also extension of the facilities, and also control of new technologies. In Malaysia, all new technologies have to go through the health technology assessment, and then if the health technology assessment unit approve, then only it will be taken up by the government. But this is only the government sector. In the private sector, they can adopt any new technology that they want, and they have very little control. Substitution of hospital care has been encouraged. For example, the hospitals are encouraged to conduct, the ambulatory surgery, for example, but this is not done that extensively. In terms of long term, including the manpower planning and specialist training, I've already mentioned earlier on that one of the action taken by the Malaysian government is to train the specialists locally. This will actually save a lot of resources than sending the people to go out and do the training. However, certain number of specialists, after they have qualified locally, they were sent to actually being trained for additional skills outside Malaysia, but on shorter term. In terms of indirect control, I want to highlight here the important aspect of generic utilization of drugs. Malaysia is actually quite strong in controlling this. There are most of the time we will give priority to generic drugs rather than the branded drug in the prescription. And then restriction of sales and promotion also being conducted so that it will actually help to reduce the cost. In terms of medium-term indirect control is a global budget. Most of our hospitals being paid or being budgeted using a global budgeting with some controls. Over the years, Malaysian hospital, especially the teaching hospital, have started to use case mix payment. This is this case mix payment is being used in order to actually clarify or actually to prepare the budget. So the hospital will calculate their case mix of hospitals, and then after that they will actually devise or organize their budget based on their case mix so that they will get a better budget rather than just based on their past year performance. Cost sharing is being done. For example, certain procedures in government hospitals are being charged at a lower price than the private, but people have to bear some of this cost. In terms of long-term measures, the indirect control includes disease prevention, which is very important, that it can reduce the prevalence of disease in long term, health promotion, and as well as the public education. So in conclusion, Malaysian healthcare system has undergone series of gradual development since the pre-independent era. Priority given to primary healthcare and also rural development has benefited most of the population. You can look at the overall achievement in terms of the indicators of health status. The new challenges in health system, especially sustainability in terms of the financing and also management of chronic non-communicable diseases, has strained the current system and may make the long term will be unsustainable. Malaysia has carried out some direct and indirect cost containment measure in order to maintain the health system, but we still need a real reform in order to provide an effective and efficient as well as equitable and innovative services to the Malaysian population. With that, I would like to thank you for inviting me to speak in this conference. Thank you so much.
Thank you, Professor Al-Junid, for your wonderful and interesting talk. We'll move to the fourth speaker, Professor Dr. Laksono Trisnantoro, Master of Science, Doctor of Philosophy. Professor Laksono is a professor in health policy and administration and head of newly established Department of Health Policy and Management at Faculty of Medicine, Public Health, and Nursing, Universitas Gadjah Mada, Indonesia. He obtained his medical doctorate from Universitas Gadjah Mada in 1987 and Master of Science in Health Economics at the University of York, United Kingdom, and got his Doctor of Philosophy from London School of Hygiene and Tropical Medicine in 1993. He is currently the Chief Editor of Indonesian Journal of Indonesian Health Policy. His main interest is in health policy and administration, especially health service decentralization, equity, and disaster management. He serves as consultant for Ministry of Health and local government for many years. During COVID-19 pandemic, he leads a team for new disease knowledge management. I would like to invite you, Professor Laksono, please, Professor.
Yes. Good afternoon. Good morning still, yeah. Thank you, Ibu Indah. Can you hear me?
Yeah, I can hear you clearly.
Yeah. Okay. Thank you very much. So, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Salam sejahtera untuk kita semua. Yes. Can I have my own share screen?
Yeah, you can share from your computer, okay. Professor Laksono.
Okay. Can you see PowerPoint?
Yeah.
Okay.
It is. Yeah.
Yes. Okay. So I try to have presentations in what the topic is, health insurance policy, but I will go deeper under COVID-19 pandemic in Indonesia. And this is the presentation that I try to bring this using the new and the latest data. I have some parts of this presentation. One about the overview of health sector situations under COVID-19 impact. And then UHC issues in Indonesia, and I bring the issue of too much depends on weak central government budget. And then major financing challenge under the COVID-19 pandemic, and the last is health insurance policy in terms of financing policy options. Okay, let's go to the first chapters about the overview of the health sector situations. And we understand that we have what we call the policy under two laws in 2004 Asian law and BPJS law in 2011. And it provides large medical benefit, including cancer treatment and also organ transplantations. So if we look at the key economic indicators of Indonesia from 1980 to 2017, you can see that we have a very steep increase of GDP per capita. You can see in this table. Also, we have the the things that population also increasing. But we have disseminating or decreasing tax revenue percentage of GDP from 21% to about 10%, and now we go down to less than 10%. That means our tax system failed to take the opportunity of the economic growth. Yeah. And then it's very important to have the current health expenditure that also increasing in 2000, but declining since 2010, and now is around 3.2% of GDP used for health expenditure. Okay, so if you look at this GDP increase, this is the blue graph, is increasing very steep. But again, back to the issue, this is the tax collection. It increases, but in very, very much lower. So that means the tax ratio is hovering at around 10%. And if we look at the supply side, we can have the public hospital owned by government and non-profit private organizations, and the private hospital owned by for-profit private organizations. And we have, this is very interesting, growth of hospitals. We can see that for-profit hospitals grows very fast, and this is in Regional 1 in Java Island. But the public hospitals, the non-profit and the government hospitals is looks steady. Some they move into for-profit hospitals, so it is very, very different pictures of growing. So that means we have also the two-tier system. Some private hospital for profit, they opt to not cooperating with BPJS. So they serve only paying patients or non-BPJS patients. And these hospitals have differentiation study to target the economically capable people who do not want to enroll as BPJS health members and do not want to use BPJS benefit package. Okay, and now if you look at the current situation under COVID-19 pandemic, we have very, very different picture of economic growth. This is our economic growth above 4% during the last 20 years. But suddenly, because the COVID pandemic, we have minus growth, minus 5.32 in Q2 of 2020. So we have a very, very difficult situation. And this is a very important issue for addressing the policy in terms of financial policy for health insurance. And then we have the issues in Indonesia that's very interesting, that actually the objective of the laws is concerned with the health equity and access to quality health care. So equity is one of the main objective of UHE policy development. So if you look at the current development until 2019, it is very, very big achievement that we have 83.6% of Indonesian population has been covered by BPJS, and the government, the central government contribution covered 92.1 million. And the contribution in the first 5 years amounting to 150 trillion from the society using the paying memberships. And the partners consist of 23,000 first level health facilities, puskesmas, DPPs, and military Pratama clinics and Pratama T hospital. And 2,400 to 1,055 main hospitals and clinics. And the utilization, we achieve about 874.1 million utilization. It's a huge utilization in the last 5 years. Okay, but we have a big deficit since the beginning, 2014 until 2018, and in the pandemic of 2020, the deficit is becoming smaller because the number of patients on COVID is decreasing. So we have this is the deficits, and most of the deficits comes from the paid members, the PPPU membership, the non-formal workers. So you can see in this graph that these are the groups that becoming deficit in the last 4 to 6 years of implementations. And if you look at who are there, most of the deficit come from informal workers, the paid members that they have first class, second class, and third class of membership. But the green parts, they are the central government's or premium, and then government employees and the big corporations workers. They still have a very, very good payment. That's why we have issue of memberships inequity across the members of BPJS. Although we are social insurance scheme, but actually we have a part of commercial insurance segment, that is the PPPU, the paid members. And these paid members, they are making very huge deficits. Secondly, we have issue of geographical inequity because we have very, very different deployment of medical specialists and distributions of hospitals across Indonesia. And if you look at in this map, underdeveloped regions such as East Nusa Tenggara get far less benefits than the people in, for example, in our special regions of Yogyakarta. And then if you look at the things, most of the local governments that have BPJS deficit is in Java. And it is very interesting that local governments do not pay for the BPJS deficit, although the deficit is in the local government authority. Like for example, in Yogyakarta, in my province, BPJS suffered from deficit about 1 trillion rupiah a year in my province here. But in one district in Malacca, somewhere here in NTT, BPJS has like a surplus. Yeah. So that means the surplus from this region is used by province in Java. And that is the problem of geographical inequity. They are not healthy, but people in the eastern part of Indonesia or in the remote areas of Indonesia, they have problems in accessing the medical services. And we can see that the payment from the BPJS based on claims, that means if you don't have a hospital or if you don't have the medical specialist, you cannot claim the medical benefits. That is the problem. And because we have a single pool problems, not like in Thailand, the Thai system, they have at least 3 pools and 1 free pools. And in fact, we have a single pools that the budget from the government can be used by like this paid non-formal workers, the paid premium memberships. So, because single pool problems, the use of pool member budget can be done by the better off. And there's no efficiency strategy because we don't know yet who is the like members who use a lot of the medical benefits. And the most important thing is that the central government budget takes all the insurance risks. So every single rupiah should be paid by the central government, not by the local government. So that's why this is my main policy issue, that health insurance policy depends too much to central government budget for financial support. And this central government budget is a weak one. So we have a weak central government budget for financial support. And if you look at the pandemic COVID-19, it will be very, very difficult for financing. Okay, so let's go to the major financing challenge under COVID-19 pandemic. So back to the issue of the economic growth, we have the impact of COVID-19, okay? So the tax ratio is also declining. So now we have about 20, in 2019, about 9.8, and we don't know yet in 2020. I think it will be less because the economic process or development is slowing, and the tax is also difficult to be collected. Okay, and then the growth of central government budget is becoming more and more in deficit. So if you look at the deficit is already since 2017, we have a deficit here between expenditure and revenue. Now we have a bigger deficit. So if we have this kind of surplus and deficit, we can see that we have a very, very big deficit. Yes, that means we have the projection, it will be like 5.5% of GDP. It's a huge deficit. Yeah. And then the central government earning is only 1,743 trillion, and the expenses is around 2,070 and 750 trillion. So it's a big difference between the expenditure and the government income. Okay, so now the question of JKN sustainability. That is the point. So when we look at this kind of economic situation, the question is whether we use tax or private financing or both. Yeah. So we have to be very, very clear and careful to understand the data. Because from this kind of things, it is difficult to rely on tax. We have suffered from deficit since the beginning of JKN. And for making the deficit is becoming solved, that means the government should pay, the central government, I mean, they have to close the deficit. And that means they use the scarce resources from the tax not for supporting the poor and remote areas, but is trying to keep the deficit is becoming zero by paying more and more central government budget. So ideologically, the scarce government resources should be focused to support the poor and remote areas. That is the point that I have to make. Yeah. So the policy question is whether we have to use government resources, tax funded, or tapping more head finance from the private sector or non-tax finance to improve the equity and also maybe also to ensure to increase the quality of medical services. So that's why I try to have some health insurance financing policy options that we can discuss later on. One is about the option one is status quo. The law on SCSN and the law on BPJS are not revised. That means we stick to the current laws. And that means the central government budget remains the main source of funding, includes how to cope with the deficit. And this is becoming uncertainty of financial capacity under COVID-19. And inequity may increase, and financial sustainability is under questions. That is very, very important issue to be addressed by our government. And then option number two is we develop like a compartment policy, but still under BPJS. BPJS remain as the only social security administrating body. So not like in Thai they have three bodies of social security that is not into one single pool. In this option, install firewalls between paid members and the other members groups. So there should be a law that forbid the use of one budget to another groups of members. That means we have to increase the premium from paying members from there. And that means also more head finance will be tapped from GDP using private financing. But we have a political uncertainty due to pandemic COVID-19. This is option two. The option three, we have no more single pool policy. So We have the new health insurance agency, other pools for the affluent society in addition to BPJS Kesehatan. So for tapping more resources from the private financing, that means we have to free, not becoming a compulsory membership to BPJS. So people who prefer not becoming members of BPJS, they can opt out from BPJS and pay it for commercial insurance. And then if you look at the Thai experience, the Thai health insurance system, the organizing body, they don't provide or they don't have like a paid members. So all of the insurance or the UHE bodies in Thailand get the revenues from the governments or from the company, and not from paying members. So that means there's no more single pool policy. And in my expectation or my analysis, it is expected that these pools can relieve the burden of BPJS for financing the members. Again, this is becoming very, very interesting political issue, and more health finance will be tapped from GDP. Okay, so back to the pandemic COVID-19 situation. Again, when we look at the community economy, also they suffer from maybe declining, the same with the government taxation. So whether this option can be sustained, yeah, we can have a debate on this issue. But at least I will stress that option one, the status quo, is not a good option to the future, because it will increase the inequity, and then financial sustainability is under question. I think this is my presentation, Ibu Indah. Thank you very much, and then let's discuss.
Thank you, Professor Laksono, for the interesting and engaging presentations. Now we'll move to the discussion session. We have several questions from the chat box. Okay. I see several questions have been answered by Professor Aljunid at the chat box. We have some questions left, and this question from Dr. Tri from Tadulako University, Faculty of Medicine. This question is for Professor Aljunid. How is the concept of health system in Malaysia adjusting to this COVID pandemic, and what about degenerative disease?
Okay. Regarding the COVID-19, since you know that the situation in Malaysia, we are received, our budget is mainly on taxation, so the government has been allocating additional resources directly to Ministry of Health. So I think they have mobilized a lot more resources, but it is not enough. We're still having a lot of problems in terms of trying to provide the resources to manage this condition. So there is an effort from the government to allocate a lot more resources to that, to the various hospitals, especially hospitals that has been assigned to manage the COVID-19. And of course, our main problem is that we do not have enough manpower, especially when we have the second wave now. So it is still a major problem in terms of the resources. In terms of degenerative diseases or chronic non-communicable diseases, actually, not much has been done before in terms of providing resources for that. Although we do have some chronic non-communicable diseases program in public health, but still screening and also rehabilitative services as well as the support services need to be improved in long term.
Thank you, Professor Aljunid. And the second question comes from Dr. Putu Malaya from Indonesian Physician Associations. This question is for Professor Laksono. So Dr. Putu said that I think that the BPJS deficit is also a result of the inadequate referral mechanisms. And second question is, if COVID-19 pandemic lasts a long time, I think BPJS will no longer be able to manage public health insurance. What is your opinion about this, Professor Laksono?
Yes, I think this is the point that we have to look at why we have a very huge deficit. And because it is back to the issue of access and large medical benefits. So BPJS offer a very, very large medical benefits and easy access. And that very important issue that the premium is very low. So if you look at the claim ratio for the PPPU, for the informal workers, is more than 200%. So it's a very bad claim ratio. But for the poor patient by central government, the PPI is less than 100%. It's around 80 to 90%. So it is a healthy claim ratio. So my point is, when we look at back to the issue of the future of BPJS, yes, I think in my opinion, I prefer to have like the third option that BPJS is not the only pool for UHC. So UHC does not mean BPJS only. BPJS should focus to the poor and the middle class and then some subsidized premium. But we have, say, about 10% of people who are maybe they are rich, they have a choice not to BPJS. That's good. That's them to choose the commercial insurance, 10%. But they cannot use the BPJS. They have to use by their own income, their own race. Yeah. But if they want to use BPJS, they have to be in the standard class, not making like a VIP class. That is the point. But it is a very, very big difference based on this current situation. And the political, maybe political constant will be very, very high if we move to this kind of arrangement. Okay.
Thank you, Professor Laksono. And then another question from Dr. Miranti. She asks if there are any impact of changes to health insurance policy in the era of COVID-19 pandemic for Professor Laksono, and maybe Professor Aljunied can add some.
Yes, that is the point that we have to be very careful in terms of government capacity for paying health sector. So many consultants, including international consultants, always advising that out-of-pocket or private financing is bad. But I think it depends on the country context. In the context of Indonesia, that we have very, very weak taxation system, and now also the oil price is also declining. I think the same is Malaysia, Professor Junaid, that Malaysians' revenue from oil is also declining. So we have to be very careful of the role of the government financial system for health. So we have to look at the future. For the rich Indonesians, the middle class, the out-of-pocket or the private financing, it is a must. It should be like that. But for the poor, we have to subsidize them. So we have to be very careful in interpreting the points that government should pay everything. I think it will be very, very disastrous for every government if all of the Indonesian people should be subsidized in terms of medical care by the government. We cannot afford to pay this kind of things. Yes, and after or during the COVID-19 pandemic, if you look at the economic growth, you can see that the burden for the central government will be very, very high. So we are now running in more and more or larger deficits in terms of expenditure and revenue of the government financing. That is the point. Thank you.
Can I just add to that, Madam Moderator? There are two issues regarding COVID-19. COVID-19 is a pandemic. When we say it is a pandemic, it's a national disaster. Then many countries, especially in the region, the government take the responsibility to provide the services. But there are two parts of the COVID-19. Number one is the public health aspect, where people have to be mobilized to go and do the public health aspect of preventing infectious disease, especially to do the contact tracing, to give education to the public and all that. And as we know that most of the time, this is done by the public health division of Ministry of Health, and they are normally underfunded from before. So as a result, a lot of resources have to be given. Contact tracing, which is one of the important aspects being done by many countries, is very expensive business. It was shown in the studies that for every one contact that you need to trace, it costs about 100 man hours of your staff, which means that's very expensive and need a lot of resources. The second part of that, we have the clinical aspect of COVID-19, which is being managed in the hospitals. And this is very expensive because the patients, nearly about 10 to 20% of them have to be managed in the ICUs. What I saw in many countries, especially Indonesia, the payment for COVID-19 patients to the hospital and to the practitioners are being done based on length of stay. This is very dangerous. If you do that, then it's more likely that it will actually induce unnecessary length of stay because the longer the patient was kept in the ward, the longer would be the more money that will be made by the hospital. So I think that we better think about that mechanism of paying based on length of stay, other than maybe we should use more efficient method of payment, such as a package payment or things like that. So these are the two issues that we need to look at in terms of the resource utilization for COVID-19 pandemic.
Thank you, Professor Aljunied and Professor Laksono, and for the interesting discussions. Hopefully all the participants has clearer or better understanding on the health insurance both in Indonesia and Malaysia. I think the time is up, so we have to close this second plenary sessions. We will give applause for both Professor Aljunied and Prof. Laksono for the interesting and wonderful presentation and discussion. Thank you very much.
Bu Indah, maaf saya lupa mengganti mengganti itunya apa backgroundnya. Sorry, I'm sorry. I forgot to change my background.
Ya, tidak apa-apa, Profesor Laksono.
Yeah, thank you.
Thank you so much.
See you.
Thank you, Dr. Indah, for moderating our second session. Ladies and gentlemen, with ending the second session comes also the end for today's seminar. The committee would like to express our deepest appreciation to all our speakers and to all our honored invites. I would like to shortly read our invitations to today's seminar. Yang kami hormati Kepala Dinas Kesehatan Provinsi Sulawesi Tengah, Kepala Dinas Kesehatan Kota Palu, Kepala BPJS Kesehatan Cabang Palu, Kepala BPJS Kesehatan Cabang Luwuk, Ketua Arsada Provinsi Sulawesi Tengah, Ketua Persi Daerah Sulawesi Tengah, Dekan Fakultas Kesehatan Masyarakat Universitas Tadulako, Direktur RSUD Undata Palu, Direktur RSUD Anutapura Palu, Direktur RSUD Madani Palu, Direktur RSUD Kabilota Donggala, Direktur RSUD Torabelo Sigi, Direktur RSU Tadulako, Direktur RSU Woodward, Direktur RSU Budi Agung, Direktur RSU Samaritan, Direktur RS Bayangkara, Direktur Rumah Sakit Tingkat 3 Dr. Sindu Trisno, Direktur RSU Sis Aljufri, Direktur Akbid Cendrawasih, Direktur Akbid Graha Ananda, Direktur Poltekkes Kemenkes Palu, Ketua Stikes Widya Nusantara, dan Ketua Stik Indonesia Jaya. Terima kasih atas kehadiran tamu undangan kami. Akhirnya kita telah sampai di penghujung acara. Terima kasih banyak kepada seluruh panelis, moderator, serta para peserta yang telah menyimak acara dari awal sampai akhir. Semoga banyak ilmu yang didapat untuk diaplikasikan dalam kehidupan kita sehari-hari. My apologies if there have been any mistakes in guiding today's seminar. Our deepest gratitude to all our speakers and participants for the opportunity and knowledge. We hope you will all stay safe during these difficult times. We have now come to an end to our seminar. Just for an additional information, the attendance for today's seminar, there is a link that has already been displayed on the screen. You can access it to that link. Dengan ini saya Rika Marina mengucapkan terima kasih dan memohon maaf bila terdapat kesalahan selama memandu seminar hari ini. Dengan ini acara internasional seminar oleh keluarga alumni Gadjah Mada cabang Sulawesi Tengah saya tutup. Selamat siang dan terima kasih. Thank you very much everyone for your attendance and good afternoon.
Terima kasih sekali.
Terima kasih Prof. Laksono.
Mohon perhatian untuk semua peserta sebelum leave dari grup. Saya mengundang untuk kita foto bersama. Nanti akan di screenshot oleh panitia. Silahkan para peserta, mungkin pembicara, our speakers that are still present, silahkan menyalakan, aktifkan video, kita akan foto bersama. Oke, terdapat 15 slide, 15 halaman untuk daftar untuk peserta sejumlah 360. Saya akan mulai screenshot satu persatu. Yang pertama berawal dari slide pertama. Siap, senyum. Oke, siap. 1, 2. Oke, slide berikutnya. Oke, slide berikutnya. Oke, slide keempat. Slide kelima. Alhamdulillah. Slide keenam. Slide ketujuh. Slide ke-8. Slide ke-9. Slide ke-10. Slide ke-15. 11, maaf. Slide ke-12. Slide ke-13. Dan slide terakhir. Baik, terima kasih kepada seluruh peserta yang telah hadir. Terima kasih, semoga semuanya tetap sehat. Terima kasih dan selamat siang. We would also like to thank our sponsors for allowing us to be able to hold this seminar, to Apisena, and also to Bank BNI for allowing us to conduct our seminar for today. Thank you. Silakan peserta untuk link kehadiran terdapat dalam tampilan layar. Terima kasih. Di dalam link materi, untuk link materi ada di chat box. Silakan diakses melalui chat box. Terima kasih semuanya.